All right, why don't we get started? I think more people will be coming in. So thank you for coming so early after the new year. I'm really pleased to introduce today Dr. Rosalie Steinberg, who many of you may know already. Dr. Steinberg got her BA from Columbia University. She is another American. I'm sorry we got so many Americans here, including myself. And Master of Science in Health Policy and Management from Harvard School of Public Health. She went to McMaster for medical school, and she worked before she went to medical school and became a psychiatrist. She was in a senior leadership position at Cambridge Hospital in Boston. It's CAMH, and at Mount Sinai Hospital. And most recently, she was served as Director of Community Development and Strategic Planning for Mount Sinai Hospital. She recently completed her medical school and then residency in psychiatry, and we're really glad to have her join us here at St. John's. You started in October, is that right? Yeah, so we're really pleased to have you. So Rosalie, I'll turn things over to you.
All right, thank you. So thanks, Larry, for the introduction. People laugh because I'm a late to residency person, so this is a second career, and I'm the only resident that sat and fanned herself during supervision, so now that kind of gives you some context. This is not going down. Okay, it's not working. Ooh.
I'll try this guy.
This guy here. I'm
Working.
frozen. It was working before. Well, that's the worst case scenario. All right, so I don't have any financial disclosures, but as Larry indicated, I am an American, so I am going to disclose that. I am a dual citizen, so please spare me because I do belong to Canada as well. But I just wanted to also disclose who I voted for in the last American election, and I did not vote for the malignant narcissist. That's all I have to say. And I last voted in the Commonwealth of Massachusetts, so I think we both voted in the same place, if you still vote, Larry. So today what I really wanted to talk about was how physicians approach discussions with their patients around end-of-life care issues. My New Year's resolution Nancy, is that I'm never going to give this talk 2 days after New Year's because everybody is in a celebratory mood and I'm here talking about death and dying. So that's my New Year's resolution. But I did want to talk about how professional attitudes can actually impact referral patterns to palliative care and how psychiatry can actually be helpful and influential in intervening around some of the difficult discussions that we have. And also talk a little bit about palliative care and rehab. It's not up there, but I wanted to make this a little bit more rehab specific. Whoops, wrong way. So I just want to take a poll in the room about when a patient with a life-threatening illness or a life-limiting illness should be referred to palliative care. So I want people to raise their hand if they think it's A, when all curative and life-prolonging options have been exhausted. Or B, when the patient is prepared to discuss their own wishes for death and dying. Okay, I see hands for B. At the time of initial diagnosis. 2, okay. When life expectancy is between 1 and 3 months. Okay, so we'll see where people fall in. So I want to talk about a case that I experienced when I was a trainee. This is many years ago. It's a patient by the name of Michael, who's 44 years old, diagnosed with metastatic small bowel cancer. He had a very poor prognosis. He was treated aggressively by the top specialist in the field. He was treated with first and second line chemotherapy, both unsuccessfully. He had multiple admissions to hospital for complications as a result of his cancer, and he had severely declining functional status. And the family was told, well, that's it, there's no plan C. We've tried 1 and 2, we have nothing left for you, and they felt pretty abandoned by their team. Just a little bit about his history is that he had suffered early on from familial adenomatous polyposis in his early 20s, and he had a desmoid tumor with a bowel resection and lived with a colostomy for the remainder of his adult life. And because of that, he's very optimistic that he could beat this cancer given his past history. There's a family history of cancer in the family. He worked for a big bank. He was a financial analyst, married with 3 young children. He also had a wife who was highly regarded and a physician in her practice. And faith was important to him. He was involved in the Jewish community and he had very close relationships there. So throughout his care, he had no advanced care planning. Focus was on the acute care treatment only, with the goal of prolonging his life. There was never a discussion about a DNR. There was never a discussion with his doctors about end of life or advanced care planning. No supportive or symptom management was ever offered, despite his functional decline. And he was never even offered psychosocial supports, neither he or his children. And this is a major cancer center. So 3 months since his diagnosis, he continues to decline rapidly. He has increasing lethargy, pain, weakness. His family was now in crisis. They call the cancer center and they say, you know, we're on, the ER is on redirect. We have no beds. You're going to wait in the ER. This is around the holidays. This is, you know, after a flu season. Please go to your local hospital. So he was admitted there for abdominal pain, sepsis, and further decline. And within 24 hours, his new oncologist enlisted the support of an interprofessional palliative care team and continued to give him active chemotherapy treatment because there was some value in offering that. The team elicited discussions immediately around his goals of care, which had not been done. They opened the discussion around end of life, and the family was actually relieved. They said, you know, we were afraid to ask. We were grateful that someone else did. And the wife is a physician, and she herself couldn't bring herself to have that dialogue with the team. So within 1 week of his admission to the new hospital, he received comprehensive symptom management. There were discussions with the entire family. Financial planning was initiated. They had visits from clergy, from friends. He started to plan his legacy for his children, which had never been discussed before. And, you know, they talked about, you know, what is your plan for end of life? Where do you want to die? They brought up the word death. And this was all raised within 1 week of new admission to a new hospital under a new physician. Okay, so they transferred their care there. And so what I wondered as a trainee was, why were these 2 different approaches taken with the very same patient? 2 very different physicians, but different approaches to care. And so what you see with physician 1, the first physician, is that the focus was on cure. Nothing left to offer. You're now terminal. See you later. We see this all the time. We get these patients here at Rehab. The second physician took a more integrative approach, where he continued to provide curative care and initiated palliative care at the same time. So it wasn't either or, it was an integrated approach. And so really, what is palliative care? It comes from the word pallium, which means to cloak or to shield. The focus is on symptoms, symptom management rather than cure. It's an approach that optimizes quality of life and focuses on the decrease of suffering. And it looks at the comprehensive interventions around physical, psychological, social, and spiritual support. And it can be provided at any stage of illness, with or without life-prolonging therapies. Interdisciplinary, it focuses on having a dignified and peaceful death, but doesn't hasten or prolong it. And determining the goals of care is absolutely fundamental to the delivery of palliative care. And so one of the things I want to get across is something that I learned as a trainee, which is that palliative care encompasses end-of-life care, but it is not just end-of-life care. So palliative care really is an approach to symptom management and the relief of suffering that actually can begin at the time of diagnosis. As the illness progresses, you may focus on issues of life closure or end of life or hospice care, but that is not what palliative care is. Palliative care encompasses all of that. So it can begin at the beginning, at the time of diagnosis, but rarely is offered. So how does it apply to our own populations here in rehab? So for malignant diseases like cancer, you see these trajectories where people are doing really well, they have a crash, and they never rebound from that crash. But what happens is that they're doing so well that the discussions around goals of care are never initiated until they've hit that curve and they've all fallen off of it. And other than cancer, here at Rehab, we see a number of patients with a variety of what I would call life-limiting illnesses, not terminal illnesses. Some people use that word, but life-limiting illnesses, we see these clients here. And so what we need to be aware of is the variations in illness trajectories of these clients. And it allows us to think about where is this patient going to progress along their care. The cancer is kind of the first illness curve where they're doing well and they have a precipitous decline. But the COPD population kind of represents the middle curve where you have these intermittent functional periods of decline, but it's a slow progression downward. And then you have the frailty or geropalliative curve, which we see at the bottom. And we need to be aware of these things so that we can start to think about at what point in their illness trajectory do we start initiating discussions around goals of care? Do we wait to the very end? Do we wait till they fall off the curve? And I would argue no. What about rehab? So there is some literature to suggest that involvement of OT and PT actually has significant benefit on patients in terms of quality of life. And in fact, I would say that you are all palliative care specialists here. Because many of the goals that are involved in palliative care are actually very synonymous with what we do here in rehab. We focus on improved functioning, we focus on quality of life, maintaining independence, reducing caregiver burden, reconditioning, pain and symptom management. All of these things overlap with palliative care, and we do it here. So I'm sorry that Murray's not here, because Murray has often said to me, this person is palliative, they should not be coming to rehab. And I would argue this person is palliative and rehab may be able to help them. So it depends where they are on their illness trajectory. And in fact, rehab has become an important component of palliative care and has actually been linked to prolongation of life and increased survivorship. And so if a patient does have a life-limiting illness or a terminal illness, they can benefit from the interventions that we have here in terms of the goals that I had previously listed. So I would like to argue that it's not just for end-of-life care, and rehab is an important role to play. So why should we intervene early? Why the early intervention? Well, unrelieved symptoms lead to a loss of dignity, poor quality of life, and unnecessary suffering. From a psychiatry perspective, I know that at least a quarter of the patients that I would see with life-limiting illness suffer depression. And there's a significant underreporting of depression, especially in the elderly. And I'm really glad, Ina, that we're trialing this PHQ-9 screening on A3, because I think we're actually going to pick up a lot of cases that would probably go unrecognized. So really, distress can be so overwhelming as to hasten the desire for an early death. And one of the things that I think has some relevance to the MAID discussion that we're all hearing about now is that patients who have unresolved or unmanaged symptoms covet death. And they are the ones who report the most pain, the most isolation, the most lack, the least social support, loss of dignity, and hopelessness. And my colleague Harvey Chachinoff in Winnipeg has done some research to show that if you actually provide early palliative care to manage symptoms, almost 2/3 of these patients will actually rescind their request for assisted suicide. So I know there's been a lot of talk about, ensuring that people have access to MAID if they want it, but frankly, my opinion is that if we had better access to early palliative care, fewer people may actually be requesting MAID, or may actually change their minds. So again, I was really interested in why these two physicians varied so differently in their approaches. What was how did they get that way? So, it's multifactorial. Physicians talk about a number of barriers, the stigma related to the term, educational barriers, and there's also some individual factors that influence how physicians behave and interact with their patients. So, physicians often talk about some of the barriers in that they have great difficulty predicting death. They just don't know. That if they talk about palliative care, that it signals to the patient a loss of hope, or they make the assumption that the family doesn't need it, or that it just takes too much time, or just there's no time to have these discussions, and so they don't engage. A number of physicians have talked about the actual name palliative care, and maybe we should change it to supportive care. It has negative associations with words like hospice care and end of life. And oncologists actually reported that they were more likely to refer to the supportive care program for symptom control in newly diagnosed cancer patients rather than the palliative care program. So where do these negative messages come from? How are they perpetuated? And I would say that our training has a lot to do with it. We have our formal curriculum, which is what they teach us in class, and our informal curriculum, which is what we observe at the bedside. But then there's a hidden curriculum, which are the messages that are not explicitly taught, but they are experienced by trainees based on what they see their staff do. So I wonder, if people can think about their training experiences and what they observed and what the messages were sent as they were going through their medical training around the concept of palliative care. What did their staff person say? How did they engage in these discussions? Did they avoid them? So these are the things that trainees pick up on. And so there was a study done around the implicit negative messages that trainees sort of acquired in their training, and on a national survey of medical students, they said that when they were going through training, death was the equivalent to medical failure. That palliative cases were taught as not good teaching cases, or that palliative care was not a core competency, or that engaging in this would be an unrewarding experience. And so the impact of these educational experiences actually impacted their attitudes and their behaviors and their care down the road as these trainees matured into practicing physicians. And I would also argue that there are a number of other factors that influence how physicians engage or behave with their patients. Age, gender, ethnicity, and actually the exposure to the number of dying patients in clinical practice all impact these, as does specialty. And so internal medicine subspecialties like cardiology and respirology rated themselves as very low in terms of their knowledge and comfort with palliative care compared with their oncology or internist colleagues. Hematologists actually had the lowest rate of referral to palliative care, and then the highest number of admission to ICU for their patient populations. Specialists, compared with GPs, said that they were less prepared than their general practitioner counterparts to provide palliative care and end-of-life care. And the academics were the worst. They were less likely to refer to palliative care or rely on primary care because they wanted to maintain control over their patient. And there's this oncology conundrum. So oncologies report that they know a lot about end of life and palliative care, but it's really inconsistent with their referral patterns. They refer more often than their colleagues, but they actually wait longer and much later in the disease course until that patient has hit that other side of the curve, and sometimes it's too late to intervene. So knowledge doesn't necessarily equal practice. And Gary Roden down at Princess Margaret Hospital did a study on the fact that his oncology colleagues did refer but waited too long, and often it was too late to actually put some of those interventions into place. And so you end up with these two categories of physicians, the sort of techno-scientific biomedical type, that was more distant, that tended to work alone, that didn't really engage in palliative care, and sort of was the kind of wanting to add days to life. I can help you live longer. And then there's the psychosocial, social, emotional type, well, the Sakaya Tree types I would call, that look at quality of life, that say, you know, we can add days to life, or we can add life to days. You know, let's see how it works for you. And they tend to work in teams. They felt that provision of palliative or end-of-life care was actually satisfying. They burned out less, and they found communication was a useful process, not one to avoid. So you've got 6 months to live. Have we heard this from any physician? Aggressive treatment, we can help you make that seem much longer. So there's the surgeon in the group, okay? Attachment. So I'm not going to go into much detail, but my colleagues John Hunter and Bob Monder at Mount Sinai are CL psychiatrists who talk a lot about attachment theory. And this is how people engage in times of distress with other individuals, really based on your early relationships with early caregivers. Patients have attachment styles. They may be preoccupied or dismissive, or not want to engage, or be so anxious that they want to engage all the time. But so do we. And they wrote a book about our own physician attachment styles. And they talk about communication and treatment at the end of life relational acts. And we have to be aware of our own biases. And so perhaps some of us in this room can be considered compulsive caregivers. They want to give aggressive, life-sustaining treatment. They are overly involved. They have difficulty with just watchful waiting or just providing supportive care. And they give treatment because they want to reduce their own distress. These are the dots with preoccupied attachment and security. And some theories say they were deprived of care as children, so they're driven to provide it for others. That's a psychological theory. Then there's the good technician. This is the doctor that avoids the patient's distress, doesn't want to get involved in any kind of discussion, delegates support for the dying patient to another service, is evasive when confronted with questions by the family, very dismissive, and typically stemming from discomfort with emotional dependence in their early years. And so we can see physicians behaving this way in terms of their clinical practice. And often we get patients who are here at rehab who have not had the discussion with their treating physician about their prognosis. It hasn't been done. And the patient is here at rehab, and we have, I think, an obligation to begin those discussions here. So how do our emotions and beliefs influence care? We experience the same things our patients do. And there are consequences of not examining our emotions as physicians. Failure to identify needs, not developing goals of care, use of resources inappropriately. We're at risk of burnout and depression ourselves. So I think that it's important to think about our own relationships, our own biases, our own anxieties when it comes to having these discussions. And so there's a cognitive behavioral model where if we're anxious about having a discussion with the patient, then we have a distortion that actually the patient is too anxious to engage in the discussion, so we don't do it. And then it leads to skill deficits. My learners are anxious and they're more difficult to teach, so we don't do it. So we avoid teaching, we avoid talking to our patients, we avoid engaging, and we don't have these clinical encounters. And so this is a CBT type of understanding as to what's going on with the doctors and their patients and their students. So I think we need some time for self-reflection. And self-monitoring and reflection is absolutely critical. And one of the things that it asks us to do as physicians is to identify our own risk factors, to really take some time and look at our own behaviors and feelings, and actually, to consult a professional colleague, speak to a trusted friend. If ever you're feeling in distress, go to that person. Go find a buddy. You need a buddy to get through this kind of work. It's not easy. And I have two mentors in the field, Harvey Chachinoff and Bill Breitbart, and I've been actually trained by both of them. Harvey Chachinoff teaches dignity therapy, and Bill Breitbart teaches meaning-centered psychotherapy at Sloan Kettering, where I've had some training. And they talk about the opportunity for psychiatry to actually intervene, not just with the patients, but also with our colleagues and our teams, the ones that we help and support. And so when I first started residency training, I was told by a CL psychiatrist that you are going to be the champion of affect tolerance. You're going to have to deal with the patient's affect, the family's affect, your teams, your colleagues, the social workers who are coming to you in distress saying, oh my God, help me with this family. And that's so we are the champions of affect tolerance. And we can help you engage in these difficult discussions. We have specialized interventions for the patients. We have cognitive behavioral approaches which can help revise maladaptive thinking styles and behaviors. We can help with emotional regulation skills, but I would caution that, we want to downregulate negative affect, but awareness alone is not enough. It can actually worsen anxiety if we don't give you practical skills on how to deal with difficult situations. We can provide mindfulness training for healthcare professionals. We have an understanding of attachment styles. Maybe we can help you understand that better. We can use our group therapy skills to run Ballant groups, which are groups where healthcare providers come together to reflect on their own clinical experiences, and I've done that before. And we can support burnout and compassion fatigue. So psychiatry can play a significant role, not just in palliative care, but in rehab and any other setting where there are difficult emotional encounters. And so I think maybe what we really need is assisted physician dialogue rather than physician-assisted death. I don't know if people recognize these individuals, but this is Larry Liebrack, who was the head of the Timmy Latner Center at Mount Sinai, who passed away and was a huge proponent of palliative care. And both were colleagues. And the other individual is Don Lowe, who was the head of pathology and led us through the SARS crisis in 2003. He died of a brainstem tumor, and he was arguing for MAID, and he had terrible suffering at the end of life. So they had two physicians, two colleagues of mine, very different approaches. So again, what do people think? I personally think the answer is C. I'm hoping I've changed your mind about this. I want to tell you about this patient, and Nancy, in my mind, was right. This patient, Michael, was actually a very close friend of mine. He died during Passover in 2011. And we dialed him in from his hospital bed to our Seder at our house. Because of the interventions of that palliative team, he was at peace with his disease. He had no regrets, he had no pain and no total pain. And what I mean by total pain is the combination of physical and psychological pain. So often I see patients who have really high pain scores. You treat their emotional pain and their pain scores come down. And so he had no emotional or physical pain. He was able to share a legacy and future wishes for his children. He wanted our children to be bat mitzvah together in Israel, which they were. We were at his bedside when he took his last breath. His family remained involved with the hospital and members of the palliative care team afterwards. Michael had a good death. I found out last night Michael's mother just entered palliative care at Sunnybrook for herself, but sought it out early, and I think also because of her positive experience with palliative care here is approaching it with embracing palliative care early on in her own cancer illness. So I just literally found this out last night. So the physician actually who took care of Michael was my husband. He still is, thank God. He was the life to days kind of psychosocial kind of guy. I would think he's securely attached, and he was trained early in his medical career by Balfour Mount, who is the father of palliative care in Canada. He sought out hospice electives early on in his career. He launched the first palliative care curriculum at McGill in 1990, so you know how old we are. And he also reflected on his own distress and eventually transferred Michael's care to a colleague because he didn't want to have a conflict of interest or be clouded by his own emotion. But that's him really advocating for early integration of palliative care into oncology care. So he treats patients aggressively while providing pain and symptom management simultaneously. So he does not see them as mutually exclusive. So take-home messages. There are a number of factors that can shape a healthcare provider's attitudes toward palliative care. these attitudes can actually influence access to early and effective palliative care. And we have to think as trainees about what we show our students, what our students pick up from the own messages that we send. We want to minimize the discordance about what they're being taught in the classroom and what we're showing or demonstrating at the bedside. I think that our comfort with death and dying is modifiable. I don't think that palliative care is just for end of life. It's not incompatible with rehab, in my opinion. And I think that Sakaya Tree can be of help in facilitating effective care and relief of patient suffering and staff distress. So I want to thank you for giving me the time to talk. I hope I didn't go over my time. And this is Michael's tallis hanging over our children at the wall in Jerusalem, where they were bat mitzvahed according to his wishes. So thank you very much. Any questions? Jeff?
I just wanted to support Mary up here.
Okay.
You say it's compatible with rehab, which it is, but I'm not sure it's compatible with our rehab.
Mm-hmm.
Yeah, we have a very short stay rehab. They here for a short while and then they go home.
Mm-hmm.
And I'm just not sure how we could fit palliative care unless we changed our whole hospital.
If you're providing any kind of pain or symptom management, if you're trying to return somebody to a better baseline than which they came in, if we're dealing at all with any of those symptoms, I don't think that the duration of our intervention precludes us from actually intervening or making them better, even the short stay patients. And not all of the patients stay briefly. There's some patients who are here for 3 weeks or longer.
Well, that's brief, I mean, compared to like another rehab.
Well, so you can do a lot in 3 weeks. You can actually do a lot. This patient, Michael, his whole palliative care team pulled it together in a week, and then he was able to have a peaceful death. So I think that if our social workers can help to facilitate discussions, if I, as a physician I'm not looking after the physical needs, but I ask my patients, so what is your understanding of your illness? I just open that up. Nobody has ever asked them, what do you understand your illness to be? What are your goals of care? Nobody has talked to them about that either. So I think that we can help facilitate those kinds of discussions, even in a very brief stay, even in short turnover, and help pass them on to the next level of care that they need, whether it's ongoing rehab or home supports or palliative teams in the community. I don't think that they will not benefit from what we have to offer. I think that we have an opportunity to fill in a gap that's not being met. Larry?
Yeah, really nice talk. I think this falls a little bit from Jeffrey's question in that I thought I knew what palliative care was and who was a candidate. And now, as I'm learning more, I know less and less. In that, I usually thought of palliative care as being for the terminally ill patient.
Exactly.
But
that's what I grew up thinking.
Everyone's. I mean, being born is life limiting.
Exactly.
Everyone's going to go.
Exactly.
So, COPD, that's life limiting, but it might be 20 years down the line. So, where I see that there are opportunities is to use those principles of palliative care for all our patients.
Exactly.
The principles apply. Where I think it is challenging is the end of life care. Like to have someone come here to die, I think that would be really hard.
I totally agree with you. And so that end of life piece requires a different level of intervention and a different type of intensity and a different type of expertise. And maybe what they need is hospice care and not rehab. But what's happening is nobody's having that discussion in the acute care setting at all. And so they come here with having absolutely no concept as to where they are with their stage of illness. That discussion has not taken place.
I love the talk, and I just finished reading When Breath Becomes Air.
Mm-hmm.
And I don't know if you read that.
Not yet.
But it's very interesting to see, he was a neurosurgical resident, and his oncologist had him go back and finish his residency training and in the OR for hours at a time, and told him he had 5 years to live. He actually interviewed for staff positions, and he died within sort of a month of that conversation, saying that he had 5 years to live. And so it's sort of interesting to see, did he have dates to his life or life to his days? yeah, very, very interesting book to read.
I actually use that line with my patients. I tell me what's more important for you. Do you want days to life or life to days? We can give you life to days. We can do it for you here. You know.
I find it challenging. I'm just going to echo a little bit of what said. What I find challenging is sometimes not even so much that that conversation hasn't been had, it's the choice that the patient and the family not to have that conversation and to push to come here. And that's, I think professionally, that's what we struggle with mostly, because we kind of understand that people don't really have much and you want to be spending your last little while here. But I do think there's value certainly using palliative care approaches and having those conversations and even connecting to family life. With patients here who maybe didn't have those conversations yet, because we also get those patients who are just kind of at the beginning of the journey and should have had some conversations about what you want to do and how you want it to look. And that's a big struggle for me, because certainly I can't bring it up, but I always want to try to kind of say, well, give it some thought, have time to think about it before you have the discussion with the patients.
It's interesting you say that the families don't want to have the discussion. I found in my experience the families do want to have the discussion. It's just that the physicians prior to getting to you have not created a setting or an environment to actually open the dialogue. And so more often than not, people know what's going on. They know, but nobody's opening the door for them to actually talk about it. But it's true that some patients and families say, we don't talk about cancer, we just don't talk about it in our family. I've seen that. Yeah.
I had a sister in palliative care and at Sunnybrook. And the palliative care physician that was looking after her, I would ask him several questions and he shut me out. He didn't want to discuss anything. And then he took it very personal when I was asking him questions. And I said, I know a little bit, but I don't know enough. So I'm asking you your opinion on this. And he wouldn't discuss anything with me. And he thought that I was challenging you. Well, if you're not happy with me as a physician, then find somebody else. And I said, that's not what it is. I, specifically want to know this, that, and that, and that. And he was thinking I was judging him.
So I would either say that physician was very burnt out or had a dismissive attachment style and was probably very mismatched for his profession.
Yeah.
And I'm sorry you had that experience.
Can I ask another question?
Yeah.
MAID.
Yeah.
So do you, a lot of people, I think, don't know about MAID, so they wouldn't initiate the conversation. Who would initiate a conversation about MAID? I know you said about if they have rehab, then maybe there's not a reason for MAID.
The patient can initiate the discussion at any time. We have an obligation, we can talk about the policies that have just come out, Larry. I don't want to go over time, but to respond to their request and to give them the option to be assessed for eligibility. But there's clear guidelines as to what falls into being qualified for MAID. It has to be, imminent, life-limiting, irremediable illness. I've had psychiatry patients ask me for MAID.
But if the patients themselves don't know, is it something that you would approach with?
Me, personally not. No.
But any physician, would any physician?
There are designated physicians at Sunnybrook who are qualified to be MAID assessors, and you can contact them. Yeah. But I didn't want to get into the MAID thing. It's okay. I'm not a MAID expert, but we have one that we can bring to talk about it. Ellie, actually. Yeah. Yeah.
It's a great talk. I just want to hit home on your point about the training aspect of things. I think it's really important to have exposure in palliative care. So my bias is before I went into my PGY rotation, all psychiatry residents have to do a month of palliative care. I thought it was going to be all death and dying, and we're just helping people at the end of life, but it's totally different than that. I think having that early one is really important aspect of training, and I think it's really the only specialty where you actually get to give patients what they want. There's no fighting over medications or anything. So it was a really eye-opening experience for me when I went through it. I'm not sure how you felt.
I almost went into palliative care as a specialty. It was one of the most rewarding experiences I ever had, to be able to see that families could actually come to peace, that children were not suffering as a result of watching a very bad death. that they had time to have discussions with their parents, you actually can create generational benefits by doing this well.
I want to just get back to what Amanda raised, the book,
Yeah.
When Breath Becomes Air, because in that book I was struck by the oncologist. It's a true story. It's an autobiography. Didn't want to talk about how much time you have left. That's not a subject of discussion. And it just strikes me as patients may have different needs or different desires. Some don't want to talk about it at all. Some do. And it feels to me like our job is in part just listening. Where do they want to go, rather than telling them this is what you're going to,
Exactly.
that's what you're going to take.
Well, it means giving up a little control on our end. So I don't know if anybody else. Sorry, if you're very depressed, you can go lie down over there. Sorry. If you're still hungover, I'm sorry to bring you down.
So I would just, thank you so much for the presentation. I would challenge everyone here to consider for the future circumstances where whether it's been bad death or good death, and how we can bring that back and present that again, because I think this is something we have to talk more about. And I feel like, and when I think of the circumstances where we've run into it on the 4th floor, it's usually been patients who came to us with reasonable goals. But then what really struck me was that chart that shows the very sudden bell curve down, because that's what sometimes happens while they're here. They were given a 9-month prognosis, but suddenly it's now much shorter. And I think we can learn from sharing our own experiences amongst the rest of the hospital. We can learn from that, because I think we have a lot of growing to do in this regard.
I agree.
So something to consider.
Something to consider.
For those in the room.
All right. And the cancer patients are not going away. You may wish them away, but they're going to keep coming from Sunnybrook. So we have to figure out how to manage them. Thank you. Happy New Year.